Dr. Shamini Selvarajah is a clinical laboratory geneticist and assistant professor in the Department of Laboratory Medicine and Pathobiology, Cytogenetics at the University of Toronto. She holds a PhD, FACMGG, and FCCMG. So without further ado, I will stop sharing and then allow her to proceed with her presentation. So yes, please go ahead, Dr. Selvarajah.
Hello, hi. Thank you so much for the invitation to speak on this topic. It's something that is very important to me. So in my capacity as a lab geneticist, the work I do is to develop and apply molecular techniques to diagnosis. So it's mostly focused on acquired cancers as well as inherited cancers. So I'm going to start sharing. Okay, so basically, during the course of this talk, I'm going to first start off with sort of a very brief overview of DNA damage repair alterations in prostate cancer. And then I'll go on to talk about some of the key principles in germline or inherited alterations, as well as somatic and inherited, somatic or acquired alterations. And then I'll give an overview of genetic testing in prostate cancer, what kind of modalities I used. I'll also touch on the pathways for these two different types of testing, and focus on the importance of identifying men with hereditary cancer risk, as it has implications not only for the patient themselves, but also for their family in the form of cascade testing. I also would like to share a couple of very generic clinical lab reports, just so that you understand what the different sections of the report actually are referring to. And then finally, I'll touch on when to consider genetic testing in prostate cancer and the different provincial criteria for germline and acquired cancers. So during the course of this talk, I'm really not going to focus just on the recommendations. I wanted to sort of give a very broad overview of the different types of genetic alterations in prostate cancer to be aware of. So some of you may already know prostate cancer is actually quite common. For 2023, it made up about 21% of all new cancer diagnoses in men, with the exclusion of non-melanoma skin cancer. Now, the 5-year relative survival rate is very high in men with localized and regional stages, and then it drops as you go to more advanced disease. Now, prostate cancer cells are very reliant on something called the androgen receptor. So that's why very often in advanced cancers, androgen deprivation therapy is one of the first treatments that are given to men, and it usually elicits a response because the prostate cancer is so reliant on this androgen receptor signaling. However, very often over time, you do get a reactivation of this androgen receptor, and that's what sort of pushes it to castrate resistant prostate cancer. Nowadays, there are more potent, powerful AR inhibitors, and that has improved survival, but you still do see this resistance that keeps on evolving. So there's a need for better options and more focal targets. So I wanted to switch to DNA damage. Now, our DNA is continuously exposed to a range of assaults, environmental assaults as well as endogenous. So with endogenous, I'm talking about DNA replication errors, and for environmental, it's more of UV light, radiation, carcinogens. And so what we have is our own cells have a network of different DNA damage response systems, which recognize all these different damaging agents that you see on the top. So you can have sort of 3 different outcomes as a result of damage and then repair by a system. The ideal situation is when you have perfect repair. So you have the damage occurring, and then you have a DNA damage response kicking in, and you have complete repair. Sometimes you have failed repair, and that this leads to cell death. However, you can also have imperfect repair. And what happens here is you have an alteration, a pathogenic or deleterious alteration or mutation in a gene that is involved in this DNA repair. So then what happens is you have an imperfect repair that leads to accumulation of mutations that would have been fixed. And this reduced efficiency of the DNA damage repair is what promotes cancer initiation and progression. Now, this is another way of representing the previous slide. So it shows all the different types of damage that can happen to your DNA. And then you have the different types of repair systems. But the two systems I want you to sort of focus in is one is called homologous recombination and the other one is called mismatch repair. So with homologous recombination, you have genes such as BRCA1, BRCA2, PALB2 ATM genes you would have heard about probably. And these are the ones where if your tumor has one of these alterations, it may be responsive to PARP inhibition or platinum agents. And about 20 to 25% of men who have metastatic prostate cancer have defects or HRD defects, homologous recombination defects. And about half of them actually have these alterations in their germline, or these are inherited. And we call that hereditary breast ovarian prostate cancer syndrome, also called King syndrome. On the other hand, you have the mismatch repair system, and you have genes such as MSH2, MLH1, as well as MSH6 and PMS2, which I didn't put over there. And these alterations are seen in about 5 to 7% of men with metastatic prostate cancer. They have defects in the mismatch repair system. And if you look at all prostate cancer stages, across the board, about 3% of them will have alterations in these genes. And when you have an alteration in these genes, you may be responsive to immune checkpoint inhibitors or immune therapy. And the pie chart on the left here basically has the results of a study. They looked at about 700 men who had metastatic castrate-resistant prostate cancer, and they looked at the status of 16 genes. And as you can see, the ones that are most frequently involved is the BRCA2 gene as well as the ATM gene. And in this study, where they found about 20 to 25% of men had these alterations in the homologous recombination pathway. So I mentioned germline versus somatic. So these are the two different kinds of alterations that can lead to cancer. So let's say we're talking about the BRCA2 gene. Now, on your left, you have images sort of describing what germline variants are. So germline variants occur in gametes, so in the egg or sperm. And because they occur in the egg or sperm, they can be passed on to children. And this can happen 50% of the time, or you have a 1 in 2% chance of passing on this alteration to your children. So when you have development, this variant ends up being copied into every single cell, so that every cell will have a functional copy and then a dysfunctional copy. In order for the cancer to actually develop, post-conception, somewhere along, you end up getting a second hit to that gene. So both of your functional copies are knocked out, and that is what drives tumor formation. Now, on your right-hand side, we talk about somatic variants. So these variants are not heritable. So they occur in all the non-germline cells. So it's anywhere, such as a prostate. So these occur spontaneously post-conception. And because they're not occurring in the gametes, they're not passed on to children. So the first somatic hit actually occurs sometime post-conception. And then you get a second hit as well, the copy that ends up knocking out now both copies. So the difference between germline and somatic variant in BRCA is with germline, the first hit is actually happening at conception, whereas in the somatic scenario, you get the first hit happening post-conception sometime later on after birth. Now, when you look at hereditary cancer, you can suspect that you might be looking at a familial cancer by looking at certain patterns in family histories. So one is age at diagnosis. Generally, cancers that are inherited tend to occur earlier than in individuals who just have acquired cancers that you see in the general population. So instead of, say, developing a cancer in your late 60s or 70s, these patients would have developed their first cancer sometime in their 30s and 40s, and unfortunately, sometimes even earlier. The other thing that would make you suspect that there might be a familial cancer or a hereditary cancer is when there's family history of certain rare cancers, such as males having male breast cancer. So that is a rare cancer, and that's why men who have breast cancer are immediately sent for germline testing to see if maybe carriers of these alterations. The other thing is also sometimes having cancer in close relatives. So this is a pedigree. It shows the grandfather, grandmother, and then the two sons and their children. So in blue, this is basically showing individuals who have cancer. So this would be a male with prostate cancer or breast cancer, and then you have both his sons having cancer as well, and then one of the sons with their offspring having a cancer too. So you have the same cancer in two or more close relatives on the same side of the family in multiple generations. You can start suspecting that there might be a hereditary cancer in there as well. The other thing is also having more than one or close relatives with prostate cancer, where at least one has a very high risk of metastatic disease, or when you have two or more relatives who have combination of prostate, pancreatic, breast cancer, and that's regardless of age or stage. So again, in this pedigree, you see the grandparents, and then you have this one child, or the second generation, an individual has pancreatic cancer, and then in third generation, you have one individual with prostate cancer, another individual with breast cancer. So you have close relatives that have these cancers. So there are patterns that you can sort of look at and start to suspect that there may be an underlying hereditary cancer. So why is knowing if you have a hereditary cancer important? Well, it comes down to something called cascade testing. So when somebody has a hereditary cancer, and in the case of prostate cancer, men who have castrate-resistant prostate cancer have a 1 in 10 chance of that alteration actually being germline. So that means they have a 50% chance of either transmitting to their children, or there's a 50% chance that their siblings also might be carriers. So just knowing that status lets them manage the risk. So it's important not only for the patient, but also for their family members, because now you can tailor the screenings. You can look at risk reduction strategies, have lifestyle changes. And so doing this germline testing to determine if the patient's carrier or not impacts not only the patient themselves, because if they have a germline variant, they themselves will need to be now screened for additional cancers, but it also gives their family members options to manage their risk if they are found to have these germline alterations as well. Another thing I wanted to point out is some of these gene alterations. So as I showed previously in one of the slides, there are several genes that are implicated in prostate cancer. Not all of them have the same risk of leading to prostate cancer. So some of them, such as BRCA2, has a much higher risk of prostate cancer than some of the other genes. Those are all DNA damage repair genes. I wanted to just include HOXB13 in here. Now, HOXB13, unlike BRCA1, BRCA2, or MSH2, MSH6, which actually have drugs that you can use if you have an alteration in there, HOXB13 does not have any kind of treatment. It's just that HOXB13 has been associated with familial cancer. So all of these genes, they confer risk for developing cancer, but we are also learning that it's not just this specific gene itself. We're learning that there may be other factors that actually is additive or impacts how and when the patient actually develops cancers. So it could be additional genetic modifiers, some of which we're just learning about, and other ones that we have yet to discover, as well as lifestyle factors. So when genetic testing is done in prostate cancer, because of what I mentioned earlier about germline testing and looking at acquired alterations, the goal, there are actually two goals. One is treatment driven, and that is to really look at the patient to see, if they can do somatic testing, which is basically tumor testing, to determine if the patient has alterations in gene where you can either target them with, say, platinum agents, PARP inhibition, or immunotherapy. So that's sort of predictive. It's trying to predict whether the patient will respond favorably to certain treatments. The other one is risk-driven, and this is to look at the patient's blood sample to look at the germline DNA and see if they have any deleterious or pathogenic alterations that would impact not only their treatment options, but also contribute or give them risk reduction or surveillance options for the patient themselves. And also whether it might, if they're found to have a germline variant, it also enables the family members to undergo cascade testing. And generally, when germline testing is done, it also incorporates the patient's own medical history as well as family history. So when you do genetic testing in prostate cancer, as I mentioned in the previous slide, you have treatment-based goal, and then you have the risk-based goal. So when you look at tissue biopsy, that is usually done for determining treatment or determining if the patient might have a target that can be sort of amenable to certain treatments. So tissue testing is sort of considered the gold standard in molecular diagnostics when it comes to cancer. This is to see if there might be any clinically actionable alterations to inform treatment options. So when you do tissue testing, you are actually going to be picking out somatic and germline variants. But when you get a result with tissue biopsy and you see a variant, you cannot really determine whether that variant is germline or somatic. You have to follow that up with germline to determine whether it's inherited or acquired. So that's the limitation of tissue biopsy. The other test is looking at your germline DNA, and this is obtained by looking at the leukocytes or white blood cells, which are found in the Buffy coat, and this is used to determine familial cancer risk. When you do germline DNA testing here, you really cannot pick out any somatic variants. There is another type of somatic testing that is called liquid biopsy. Some of you may have heard about, it's also called plasma ctDNA testing. And in here, you're looking at fragments of DNA that were originally from the tumor that are floating in the plasma. And when you sequence that, you could be sequencing either the germline or somatic variants. Like the tissue testing, it cannot distinguish but one from the other. So you have to actually follow that up with germline testing. The whole liquid biopsy testing has limited clinical availability. And this is partly because in most of the provinces in Canada, I think there's only one province where there is reimbursement for liquid biopsy testing. And because it's such a costly test, most labs find it very expensive to validate or set up this assay and to offer it as a routine test. But it is gaining favor because it has certain advantages over tissue biopsy, such as when you don't have a tissue biopsy or if your tissue biopsy failed during testing. So when we talk about germline testing, traditionally the model was that the patient gets referred to a familial cancer clinic or genetics clinic. The genetic counselor or the clinical geneticist will perform a pre-test counseling to explain what the test is about, to get the consent, take the family history and detailed medical history. Then they'll order the test. Then the patient goes to get the blood drawn, test is performed, and then the results are sent back to the cancer genetics clinic, and the patient receives post-test counseling. Now, this traditional model is actually or was developed to facilitate testing for those individuals who actually had a very strong family history. So because of that, it sort of necessitated that you have to do a detailed family history workup. And this ended up leading to quite a bottleneck. And so wait times could range anywhere from like 2 to 3 months to even just get the blood test started to another 2 to 3 months before you get the results. In some other places across Canada, the wait time could actually even extend to over a year. So this model is not really sustainable as the only model for germline testing. And so there were other models that were necessary to provide germline testing. And this is where something called mainstreaming came in. So with mainstreaming, the difference is it is the oncologist who is a non-genetics professional who does the ordering. So they will do a pre-test counseling of the patient, get the blood drawn, send it to the lab. The results are sent back to the oncologist. Sometimes there is an infrastructure in place where the results are sent not only to the oncologist, but it's also sent to the clinical genetics team. And depending on what the results are, the patient might actually also have a post-test appointment to get counseling if certain alterations were identified. So the main thing about this model, the mainstreaming model to remember, is when the test is ordered through a non-genetics clinic, when the results come back, it's important that the patient gets referred for genetic counseling if a pathogenic variant is identified. So this model was initially designed at the Royal Marsden in UK, and this was actually, when that was done, it was like 2013, and it was developed to try to open up germline testing options for women who had breast and ovarian cancer, who are actually waiting for months to get germline tests. And so it moved the genetics testing from the Familial Cancer Clinic to the oncology clinic. And it ended up being quite a success, not only for the patients, but also for the healthcare system. So for the patient, it saved lives, and certain cancers are prevented or addressed earlier on in the disease stage because they went through very aggressive screening once they were identified as having a germline variant. And then in terms of the success for the hospitals or the healthcare system, it actually demonstrated cost saving in the context of healthcare system, because now you are identifying patients much earlier in the disease stage, and they didn't have to go through treatment that they didn't necessarily need if the disease was addressed earlier on. So because of the success, now mainstreaming has made its way over to Canada for the past several years. It's been used in several disease models, not just for prostate cancer, but also for lots of other hereditary conditions. So when you look at germline testing, the genes that are actually tested, the aim is to get information about your own personal risk as well as familial risk for cancer. So the recommendations generally indicate that you have to test at least these genes that I've listed over here. And as you can see, ATM-BRCA2, which are quite frequently involved in hereditary cancer, are listed here, but you also have other genes like the HOXB13 I mentioned. One thing I do want to point out is while this is a minimum panel, very often across Canada in various labs, the germline testing group of genes is usually much larger. And this is because sometimes when you're looking at a patient's family history, they might have some cancers that are not just prostate, pancreatic, breast, ovarian. They might have, let's say, there might be a couple of individuals in the family who had melanoma, in which case you would also add those genes. So this is a minimum group of genes that are recommended in guidelines, but very often there are more genes that are tested. So when the testing is done, and let's say a variant was identified, labs classify the clinical significance of these variants using different guidelines. So I'm not going to go into too much detail, but I just want you to be familiar with certain terminologies just so that you can understand the implications. So in this classification system, there are basically 5 terms. There are 3 groupings altogether. So on the right, you have mutations that are considered benign or likely benign. And this is when the lab investigates the variant, they look at literature databases and when there's a lot of evidence to suggest that there is no association whatsoever of that particular gene alteration with the disease state, those variants are just classified as benign or likely benign, and they do not get reported. So you won't even find that in the report. If that's the case, generally that's the end in terms of what the next steps are. However, in certain situations, if the patient has a strong family history, the patient may go on to get tested with a larger panel of genes. On the extreme left-hand side, you have those pathogenic, likely pathogenic variants. And this is when there's a lot of literature associating that particular genetic alteration with the disease state. So in these scenarios, what happens is the patient will now get germline, will get genetic counseling, and they'll also initiate cascade testing of family members to determine if any of the family members are actually shares this alteration as well. And then unfortunately, right in the middle, you have these variants called VUSs, or variants of unknown or uncertain significance. And this is when there's a lack of evidence or there's conflicting evidence regarding whether the alteration is pathogenic or benign. So in these cases, sometimes it gets treated as a non-actionable variant until further information is available, or the patient, if they want, can still go ahead and get genetic counseling to understand what the implications are with regards to this particular variant. So this is how germline variants are classified when you see them in the report. So I have a very generic report over here, which is a report for germline testing. So there's a lot of information, but there are just two areas I'm going to focus on. So the first one is the results section. So this result section here says that a variant is detected and that this variant is in BRCA. The rest here just describes what that particular variant is. The classification is that it's pathogenic. So action number one is that for the clinician, it's to consider what implications this has for clinical management for the patient. So it's not just, what kind of screening the patient should have going forward, if there are any preventative strategies. It's also now for the family. You now need to involve the family and get cascade testing going. And that's basically the action two, which is to start looking at family members. And this box over here sort of describes what impact this variant has on the gene, or as in the protein itself. So that's not really relevant here, but it's the last sentence that says genetic counseling is recommended. Molecular testing is available for the patient's family. So one is, what does it mean for the patient? Number two is, what does it mean for the family? So those are the two main points that we always want to get across when we issue a report for germline testing. Now switching to tumor panel. So with tumor panels, because the whole aim is to determine if the patient has a mutation, or if the tumor has a mutation where you can target with a particular drug. And in Canada, the Health Canada indication for PARP inhibition is that you have an alteration in one of these three genes. You will not receive the drug for any of these other genes. So that's why very often, if you look at tumor panels across Canada, you'll see at least three these genes involved. Sometimes these additional genes are included because they may have information pertaining to the behavior of the tumor. So CDK12 is a gene that is associated with a more aggressive tumor. Some clinicians like to know that, so they may treat the patient a bit differently. But other than that, you have at least these three genes that are always included. And then for patients who have metastatic castrate-resistant prostate cancer who may be eligible for immunotherapy, you want to take a look at the status of these MMR genes. So that's basically what gets looked at when you're actually referring to tumor testing. And similarly to germline tests, variants identified in tumor testing are also classified a certain way. There are different schemas that are used by different labs. But the one that's most commonly used for tumor testing has this tiering system. So like the previous germline, you have those variants that are benign or likely benign. And then you have on the opposite end of the spectrum, tier 1 and tier 2 variants. These have strong clinical significance or potential clinical significance. And then you have the ones where the clinical significance is unknown. Now, generally, regardless of the results, for certain patients, it still warrants going to following up with subsequent germline testing. And the reason is this. So this is another way of looking at the previous different ways in which a variant is classified. So as I mentioned, in Canada, tumor testing usually gets performed with a smaller panel in prostate cancer because there are only a handful of genes that have they have utility for drug therapy. So tumor testing is usually first done in a limited panel. In this case, I've just listed ATM, BRCA1, BRCA2. Now, let's say, after the test, there is no variant identified in the tumor. If you're thinking of, let's say, if this is a metastatic castrate-resistant patient or even a patient with metastatic prostate cancer, they should still be referred to clinical genetic testing for germline tests. And this is because since patients that have advanced or metastatic prostate cancer have a higher risk of carrying a germline variant in one of several genes that are in the HR pathway, just because they didn't have a mutation in one of these does not rule out the fact that they have a hereditary syndrome, because they could have a variant in some of the other genes that I discussed earlier. So even if it's negative for a patient with advanced cancer, they should still go ahead with germline to determine if they do have a variant in one of these other genes. The other thing that can happen is with tumor testing, you may identify, let's say, a BRCA2 variant. The thing is, tumor testing cannot distinguish between a somatic or acquired variant and a germline variant. So that patient whose tumor is identified as having a BRCA2 still needs to go ahead for germline testing. And it could be that the variant is identified as somatic because the patient's germline DNA doesn't show it, or patient does have a germline variant, and that was the variant that was identified in the tumor was actually germline, in which case they would get post-test counseling. And then you have patients that would have a VUS in one of these genes. They would still need to go for germline to see if they have an alteration in another gene that actually has a role in prostate cancer, because this VUS is not clinically relevant, but they could still have a variant in one of these other genes. So that's why for certain patients, regardless of the results, it may still require getting germline testing being performed. So as I showed in the previous slides, you have tumor testing with a smaller panel and germline testing with a larger panel. Just recently, the Canadian Urological Association released guidelines for genetic testing in prostate cancer. And their recommendation is that other than BRCA1, BRCA2, and ATM, it would be best if tumor panels could be aligned with germline panels as much as possible. So, you won't have this situation where patient has to go through several successive testing. Just having the tumor panel test all the genes that you see in the germline will help triage, so that if a variant is identified as having if a patient is identified as having a actionable alteration in their tumor, they can be triaged to get subsequent germline testing. Say then a patient whose tumor does not have any alteration in all the genes that in the tumor that was evaluated the same gene set as the germline. So it helps to triage and reduce the weight or the burden on the clinical genetics lab. And that's one of the advantages of aligning tumor and germline testing. So this is a very generic report from tumor testing. Again, there are sort of two areas that are most important. The first one is the results section, just saying the patient has a BRCA1, and that it's a tier 1 variant of strong clinical significance. So action item 1 for the clinician is that, oh, the patient has a tier 1 variant in BRCA2 or BRCA1. It has implications for clinical management. Action item 2 is to refer to genetics to determine whether the variant is germline or not. And this necessitates the patient to have a blood draw in order for germline testing to occur. So when should testing be considered? So this varies a bit based on what guidelines you're looking at, and also what part or which province you're in across Canada. So according to NCCN guidelines for prostate cancer, tumor testing And germline testing should be performed in all patients who have metastatic prostate cancer. So that's across the board. However, with tumor testing, for those with regional prostate cancer, that may be considered. And then for germline testing, these are some of the criteria. So do they have regional prostate cancer? Is it very high risk or high risk, locally advanced? Is it intermediate risk prostate cancer with adverse histology? This is basically the staging of the tumor. Or do they have a family history of certain cancers? Or are they of Ashkenazi Jewish descent? So these are situations when you might want to consider germline testing. And as I mentioned, the criteria for whether a patient is eligible for germline or tumor testing varies across Canada. So in places like Ontario and BC, well, Ontario, it's very broad. As long as you have locally advanced prostate cancer, your tumor testing, you're eligible for tumor testing. In BC, it's a bit more stringent. Only metastatic prostate cancer patients have their tumor tested. For germline, in BC, it's metastatic prostate cancer patients who can have germline testing. Ontario, it's a bit more broader. But in some provinces, let's say Nova Scotia, as of, 2022 and early 2023, there was no provincial funding for tumor testing. It was done at the physician's discretion based on which institution they were in. And germline testing, though, was eligible for patients who had prostate cancer. So as you can see, there are differences from province to province. And so it's important to be aware of regional differences in policies and also to know, which biomarker testing you have access to. So it's always important to have a discussion with your doctor. So I would like to now just wrap up with some take-home points. First is genetic testing is increasing. It's becoming more and more the standard of care for prostate cancer patients. Genetic testing of DNA damage repair genes can inform selection of optimal therapies. And for patients with metastatic disease, all of whom should get germline, it can identify individuals who may have a hereditary cancer risk and a syndrome such as HBOP or Lynch. There are different guidelines for tumor testing, but they all encourage testing on metastatic prostate cancer patients. And then the new 2023 CUA guidelines recommend to align these panels so that you're looking at the same set of genes, whether you're doing germline testing or tumor testing. And there is a really big need to raise awareness for men to be tested. Now, I know from speaking with my colleagues, my clinical colleagues, one of the biggest challenges is to get men to be tested. Now, historically, there's been such a focus on genetic testing for breast and ovarian cancer. And unfortunately, men get left behind. So it's important for men to understand that the implications for them and possibly their families is important enough to get testing done. And then if you can, seek out centers of excellence with cancer genetics expertise, because this is a rapidly changing field. So we're hoping that with dissemination of new information and as well as opportunities that might be available, the outcome for patients and their families can be improved. And that wraps up my talk. I can take any questions anyone may have.
Yeah, I can just say thank you, Dr. Selvarajah. That was an incredible presentation.